Hello everyone, and welcome to the first in a mini-series of 3 lectures on qualitative evidence synthesis or qualitative systematic review. My name is Dr. Andrew Booth. I'm from SHA at the University of Sheffield. In the first of our 3 lectures, I'm going to give a brief background to the process of systematically reviewing and synthesizing qualitative research. I'm going to briefly rehearse some of the philosophical assumptions that underpin this particular methodology, and I'm going to suggest various ways in which qualitative synthesis might be used within health services research and public health. So I'm sure you're all familiar with what qualitative research is, but just to give a brief recap, we're talking here about research which seeks to explore and understand social phenomena, attitudes and behaviours. So it could be attitudes towards having a particular health condition, or behaviours in relation to receiving a particular intervention or treatment, or indeed delivering that intervention or treatment. And the focus here is on a real life context rather than in experimental settings. And the methods of qualitative research include interviews, the use of questionnaires, typically semi-structured questionnaires, focus groups, so group interviews, observation, and document analysis. So, for example, analysis of policy documents or meeting minutes. And so the data that we handle is generally textual data. It could be in the form of transcripts of interviews with mothers of children with a particular health condition, or of policymakers facing a decision about a particular public health intervention, or it could be observation notes where the researcher goes in and observes the real life context and notes down what they observe. But it could also include visual materials, so for example photos or real-time videos. The important point here is that the analysis is conceptual, so we're dealing in ideas and in themes. It's not numeric as with quantitative data. And with so many types of qualitative research available, it's not surprising to know that there are various schools of qualitative research, each of which has a different underlying philosophy, and this leads to different forms of qualitative evidence synthesis or qualitative systematic review. Importantly, qualitative evidence and its value is being increasingly recognized. On the left-hand side here, we have an editorial from the Bulletin of the World Health Organization talking about the value of qualitative evidence in guidelines and health decision-making. The World Health Organization uses an evidence to decision framework, and within that is a section on values and preferences, and this is typically populated by qualitative evidence. On the right-hand side, looking in the UK context, the organisation NICE, the National Institute for Health and Clinical Excellence, is using qualitative evidence increasingly to improve the implementation of clinical guidelines. And here we have an analysis piece by one of my colleagues, Dr. Chris Carroll, on the use of qualitative evidence synthesis specifically within the implementation of such guidelines. And it's true to say that over the years we've seen a tremendous increase in the number of published qualitative evidence syntheses and increasingly in the availability of methodology documents to help us to do this. I remember back in the early 2000s searching the Cochrane methodology register and only finding one item that was on qualitative evidence synthesis. It was a book on metaethnography dating from 1988. But over the ensuing period, we've seen a growth in guidance on the various stages of the qualitative evidence synthesis. So you'll notice I've used the term qualitative evidence synthesis. We tend in the Cochrane collaboration to prefer that term over qualitative systematic review because it's a broader term that includes methods that can be used to conduct reviews of qualitative research evidence. And as we'll see in the second of the mini lectures, there is a tremendous variety in the type of qualitative evidence that we could be referring to. And increasingly, qualitative evidence synthesis has recognition of its role to play, particularly with a movement towards an understanding of complex interventions and whole systems approaches. And the importance of this role is seen in establishing the importance of outcomes to patients, for example, rather than what can be measured. We have what is meaningful. Also, issues relating to the acceptability, the fidelity, and the reach of interventions, how feasible they are in different settings, and indeed why they may work better in some settings rather than others, and potential consequences on equity that might differ across populations or population subgroups. So just to reiterate here, in contrast to quantitative metasynthesis, or what you'll know as meta-analysis, we're actually looking for themes or constructs that we can identify either from an individual study or preferably across multiple qualitative studies. And so it's very important to get our heads around the fact that the goal that we're trying to achieve is not just adding studies together, if you like, in a mapping exercise, but it's more interpretive, getting an all-round perspective of a particular phenomenon of interest. And as mentioned, the preferred term within Cochrane is qualitative evidence synthesis. You may frequently see the term metaethnography, and that refers to a specific method of data synthesis, one of the most widely adopted, but which is often misused as a label to refer to the whole stable of qualitative evidence synthesis approaches. So I mentioned the seminal text by Noblit and Hare on metaethnography that I encountered in 1988, but momentum has picked up really over the last 15 years. In 2006, the Cochrane Qualitative Research Methods Group was registered, and at that time this was marked by a first Cochrane colloquium plenary given in Dublin that featured the role of qualitative synthesis. A couple of years later, the Cochrane Handbook recognised qualitative synthesis methods in a very well cited chapter 20 in the handbook. The conveners of the Cochrane group produced supplementary guidance, which was web guidance to take you through the different stages of the process. More recently, we've seen the remit of the Cochrane group broaden to include implementation, and in 2013, many years after that first Cochrane plenary, we saw the first Cochrane QES standalone in the Cochrane Library. In 2017, the BMJ analysis feature by my colleague Dr. Carroll appeared. In the same year, supplementary guidance in a second edition, this time published in the Journal of Clinical Epidemiology, and that is the current key source for the QES methods. The editorial that I highlighted from the Bulletin of the WHO, and under the sponsorship of the World Health Organization, a series of documents that were published in BMJ Global Health on complex interventions, which actually figured more documents relating to qualitative evidence synthesis than to its quantitative counterparts. So while we've seen increasing clarification of the methods of qualitative evidence synthesis, we've seen a bewildering proliferation of terminology, and often the labels associated with qualitative evidence synthesis can be some of the most complex ways of trying to gain an understanding. But just to try and simplify this plethora of terminology, we've mentioned metaethnography is the oldest and most established method. In 2001, Patterson and nursing colleagues in North America described the study of meta-study, which was made up of component parts including meta-methods and meta-theory. Poppe and colleagues defined what was called narrative synthesis in a UK-based project in 2002. At about the same time, realist synthesis, which strictly speaking is a mixed methodology for quantitative and qualitative evidence, bringing it together, but has many qualitative-led stages that appeared. Meta-narrative review was identified in 2005 by Greenhalgh. Critical interpretive synthesis the following year by Mary Dixon Woods. In 2007, the Cochrane Group settled on the preferred term of qualitative evidence synthesis. Within education, they prefer the term qualitative research synthesis, labelled in 2010, and in 2013, social care decided that they needed their own version and invented the label Qualitative Interpretive Metasynthesis. Now, just a personal anecdote here. My introduction to the methods of qualitative evidence synthesis came from reading this particular paper by Patterson and colleagues. This was in the late 90s. They identified 38 studies that examined what it was like to live with diabetes. Analysing these studies, they found an overall metaphor about the concept of balance, the idea of trying to keep your health condition balanced and trying to balance your intake. This really resonated with me. I could see how this could potentially be useful in explaining this condition, say to someone who has been recently diagnosed, or perhaps in use in patient leaflets or patient education. And the article also identified other themes like knowing one's body and learning how to manage diabetes and fostering supportive relationships. Within Cochrane, there are three of the methods that we've particularly privileged. Here are examples of these three types. Thematic synthesis is the, if you like, the entry level, just as thematic analysis is the perhaps most accessible method of analysis for primary qualitative research. Thematic synthesis is one of those that people find relatively easier in order to synthesize themes from published qualitative research. Another accessible approach is framework synthesis, again analogous to framework analysis that comes from primary qualitative research. And here we have an example on barriers and facilitators to lay health workers in maternal and child health. And then with more complexity, because of its role in trying to generate theory, we have metaethnography, which deals with first, second and third order constructs. So first is the verbatim extracts from the informants, the subjects of the study. Second is the constructs developed by the authors of the various papers, and third order constructs are the product of the synthesis as identified by the reviewers. And it's important to recognize that these different methods can be positioned on an epistemology spectrum indicated by this rainbow display here. There are 5 points on this spectrum, ranging on the one hand from subjective idealism, the belief that there's no shared reality independent of multiple alternative human constructions. So in other words, that humans interpret the world that they perceive in different ways, and that these have an important effect in determining the worldview, if you like. And on the other extreme, we have naive realism, which says that reality does exist independently of human constructions and can be known directly and can be elicited through realist methods. So on the one hand, you have a highly constructivist view of knowledge through the eyes of the beholder, if you like, and at the other, you have a direct window onto the world, as if it is a single real view, picture of what's going on through a window. And the importance for this particular lecture is that the methods that we describe lie on this spectrum, and that has an effect at all stages of the review. We mentioned that that rather than simply aggregating, that many qualitative syntheses seek to go further in configuring or interpreting the relationships between different themes, that we can see differences in, for example, how exhaustively you search, and indeed how you actually use the review. So at every stage, this distinction between the idealist end of the spectrum and the realist end of the spectrum has an impact on the methods that we use. And this shows this in a more instrumental way at the level of searching, quality assessment, the degree to which you problematize the literature, so the degree to which you recognize different perspectives in different types of literature, the effect on the question, the way that it addresses heterogeneity, and the ultimate product. It's important, however, to say that these are generally distinctions of degree rather than absolute distinctions, and to say too that although we've characterized qualitative research as being more towards the configurative end of the spectrum, actually this can be independent of the paradigm, so that qualitative research can range from aggregative to configurative, and similarly that quantitative research can move across that spectrum. So it's not such a simple binary presentation. From the point of view of a systematic review course, we can see that the stages of qualitative evidence synthesis are very similar to those for a conventional systematic review. They involve formulating the review question, conducting a systematic literature search, screening the appropriate qualitative research articles, analysing and synthesising the findings instead of the quantitative results, having procedures in place for maintaining quality control, and then presenting those findings. So at first view, the similarities shout out from this particular structure. But as you go into each one of these, you can actually see distinctions. So for example, should we start with a fixed question, or should part of a qualitative inquiry include that process of discovery of the question? Should we conduct a comprehensive search, or is there room for qualitative techniques such as purposive sampling? Should we apply quality criteria in selecting the studies that we include, or is the contribution to the overall interpretation more important than the study quality? And how should we present the findings? Should we do this in a conventional qualitative way through themes, or should we use other methods of presentation from the systematic review methods such as tables? So a point for reflection here, why might a health service researcher wish to conduct a qualitative evidence synthesis? I've mentioned a couple of reasons earlier on, but this is by no means the full exhaustive list. I just want you to reflect on this for a moment. You might want to pause the recording while you do this. And then in resuming, we see some of the reasons. We've mentioned experience of a disease or a condition, or the acceptability of an intervention. It can help us to identify factors determining a choice between interventions. It can help us get under the skin of an intervention to see how an intervention works. It gives a patient orientation to our decisions in terms of which outcomes matter to patients, and indeed former colleagues have used qualitative research syntheses to identify what's important to go into our outcome tools when measuring experience of a condition. We don't focus only on the patient perspective or the perspective of carers. Qualitative research also helps us understand staff attitudes. We can explore barriers and facilitators to implementation. We can explore longitudinally how has a concept changed over time, and we can also move into the territory that is currently inhabited by the realist approaches. Under what circumstances does an intervention work, under what does it not work. So we can unpick the average from a meta-analysis to see circumstances where it will work better than expected or will work worse than expected. And the list goes on further. This is a nice illustration of the role of qualitative research in a complementary way alongside quantitative research. So this is a project that we were involved in looking at repeat teenage pregnancy, so teenage mothers deciding to have a second child. And you'll see here that there are many questions to be answered, but at least 3 of those questions engage with qualitative research. How was it implemented, the intervention, analysed through thematic analysis and narrative synthesis, did it work as planned, with the qualitative data included in the realist synthesis, and was it acceptable through a conventional qualitative synthesis? And these threads could be brought together to help us understand the overall phenomenon of interest. So there's a nice summary here of why qualitative evidence synthesis or qualitative systematic reviews are important. They help us to understand healthcare issues that cannot be measured quantitatively. They help us to see how people perceive health, manage health, and make their decisions regarding health services. They help us to increase our understanding of the culture of communities, to understand how service users experience illness and engage with the health system, and help us to evaluate components and activities within all aspects of health services, including health promotion and community development. So I'd encourage you to have a look at some of these references. We return to some of these later on in lectures 2 and 3. Lecture 2 will look more at the individual components of a qualitative evidence synthesis, and lecture 3 will take you through a worked example and make some conclusion. So again, we've got further references here to support your wider reading. So thank you for your attention. I look forward to engaging with you in mini lecture number 2.